Sure.
5, 4, 3, 2, 1. Sir, we are live now.
Okay, good evening, everybody, and welcome again to today's webinar brought to you by the Orthopedic Research and Education Foundation, India. Today, we have the pleasure of having Professor Ananda Kisor Pal from Jalpaiguri Government Medical College, and he's the former head of Department of Orthopedics in IPGMER, Kolkata. So I think Dr. Pal needs no introduction in this forum because he's done multiple presentations. So today he's going to talk on common problems of the spine, how you present the cases, and tips to the solutions that you have, how you can manage these problems when you get these cases. So I think without much ado, over to Dr. Pal, and we look forward to your presentation.
Okay, good evening, Dr. John. So thank you for your excellent endeavor for continuation of this spreading of knowledge among the postgraduates. So is my slide is visible?
Yes, visible and audible.
Okay, thank you. So without wasting our time, I just want to talk with a very, very important topic, which is the problems of spine case presentation. Spine remains a little bit appears to become very complex item for the postgraduates during this final MBBS. But believe me, but it is like just a mathematics. If you know the exact what are the pros and cons and the tips, it is easy to deal with. See, so there are common problems of the spine like backache, lumbago, which is known as the lumbago, localized, diffuse, referred, or radicular. So what is that? We'll discuss. So you have to identify the pain. What is that? Is it the localized pain? It is the diffuse, referred, or radicular. Localized pain, maybe there are different types of localized pain, maybe girdle type of pain. That is a special type of pain which is coming from the dorsal region, dorsal spinal dorsal component. But there are some red flag signs like weakness of the legs, significant numbness, loss of the bowel and bladder control, fevers or the chills, or significant unexplained weight loss. So we have to be very much careful about it. If there's any of this is complained by the patient, so there may be some sinister problem. Like suppose see there are several cases. What are the cases usually we have given in our examination? Like the kidney spine, like the malignancies, or any tumors, is neoplastic condition of the spine, or some old traumatic paraplegic patients, and also the prolapsed intervertebral disc space where there is some neurological problem. So if these red flag signs are present, so beware of that. There must be some this is a case of neoplastic disease. But here we see there are some leading questions is required, because patients becomes very shy to discuss about this specific bladder complaints, and especially the erection problem. If these problems are there, this is also the red flag signs, but the patients are unable to, is very reluctant to tell that. So what are the specific history to be taken from them for the bladder complaint, like initial urgency, inability to hold the urine, urgency to pass urine, altered sensorium around the anus and the urethra, as also the loss of erection that can cause impotency. And that if these problems are there, especially the erection, severe, that's a specific, that is roots for the anus and the genital organs. There is S2, S3, S4, maybe paralyzed, that's a lower motor neuron lesion. Most commonly is a chorda lesion or the lesion. So it is very, very important to take it out from the patient. Now, back pain, I've already told it may be localized or the diffuse or non-anatomical, non-geographical or funicular. Patient is telling that pain is there, but cannot tell from where it is exactly coming. Especially, so this is known as diffuse or funicular pain. It may be some intradural, intramedullary problems of the spinal cord, or most important is the neoplastic condition. Otherwise, there are some other problems like the hemorrhage or very rarely infection. Most of the cases, infection, they are coming from the outside, so that can lead to localized pain. Suppose these are the geographical distribution. Even any person, they can try to draw this in their paper to identify which type of patient the pain is complaint of. Like the patient may be localized pain, like this may be over the back, like this. You can see here, it may be referred pain, like the facet joints. Referred pain is coming from the facet joint, sacroiliac joint, muscles, and the disc. So, what is the difference between the referred pain and the radicular pain? Radicular pain is coming from the from the compression of the root of the nerves, that is from the extradural compression, intradural extramedullary compression. What are those? I'm within seconds I will discuss what are those. But see, there is a continuous pain. There is no pain-free interval in between the source and the whole area of complaint. So this is most important for the radicular. Whereas the referred pain, there is some pain-free area from where it is coming. So suppose the patient is coming from the pain is coming from the facet joint, but the pain is complained of on the back of the buttock or the lateral aspect of the buttock. So there is some pain-free area in between the source of the pain and the area of the pain which is complained of. So this is called the referred pain. So beware of that. So that may be facet joint, it may be sacroiliac joint, that may come from the muscles or that come from the disc. Okay. Now, what are those? See, this is the anatomical architecture of the spinal cord. See, this is spinal cord. This is the this H-shaped or butterfly-shaped. These are motor cells, motor areas, and on the posterior part, these are mostly the sensory areas. As you can see, blue are the sensory area. You can see here. So, if the branch is coming from front, as you can see here from the front, so that may lead to that involvement of the motor tracts first. Lastly, it affects the sensory and bladder bowel, which is running in the posterior cord. So if there's some problems of the spine, like the kidney spine or the traumatic paraplegia, where the brunt is coming from the front, because the anterior part of the spinal column is mostly commonly involved in kidney spine. So the motor tracts is involved first. So motor complaints is involved first. Sensory is followed by sensory and followed by the bladder bowel. So this is the way of involvement from the front, from the back. Whereas if there is a neoplastic condition is coming from the back or from the lateral side. Why? Because the posterior element of the vertebra is highly vascular, and most of the cases the secondary metastasis that require some rich blood supply, and they are coming from the back. So the brunt is coming from the back. So there is involvement of the bladder bowel initially, followed by this sudden involvement of the bladder bowel sensory motor very quickly. So without involvement of the spine. So there is no local signs, but there is a quick involvement of the neurology. So that is the way by which we can differentiate whether it's a intradural or extradural. Extradural is basically coming from the outside, as you can see here, from the infection, from the trauma, from the disc, or whether it intradural coming from the center. It may be coming from the it may be intramedullary, that is from the inside the medullary canal, inside the spinal cord, or outside the spinal cord. If it's inside the spinal cord, what is the cause? Most important cause is the vascular. It may be hemorrhage, arteriovascular malformation, or hemorrhage, or there are some other neoplastic condition. Whereas just outside the medullary canal, outside the spinal cord, but inside the dura, that is intradural but extramedullary. That means that may be due to some infection, or it may be some neoplasm, or due to some disc spacings. So how to differentiate? So whether if it's an intradural lesion. So if there's an intradural lesion, see if there is a compression from the center, so there is no geographical localization of the pain, isn't it? So there is no geography, because in this area from this it cannot be stamped that it will give the specific type of dermatome. But if the branch comes from the outside, even just that involves the root, that is intradural extramedullary, that means involve the root. So in that case, that is the radicular pain. So, so if there is some intradural, that is a but radicular pain, whereas intradural intermediary at the future pain, diffuse pain. So that is how we can differentiate. But the basic difference is intradural and the extradural is extradural. It is coming from the front. That is the more fast, followed by followed by bladder, very gradual manner. Whereas if it is coming from back, that will especially the new position, that will involve the bladder bowel fast or sensory motor followed by the weakness. And the spinal local spinal problem will be very less. So this is the basic of this anatomy, and check that, so we check the direction of the attack and the structure involved. Now, designated part, diagnosed part. You can see the patient complaining of localized backache, positive local tension, spinal deformity, this gradual involvement with the motor, followed by the sensory. What is the diagnosis? Can anybody tell? Can anybody tell? Anybody? So this is the typical feature of decayed spine. Okay. So next one is the localized backache. The localized tenderness may be positive or negative. There is sudden paralysis below the knee. There is lower motor neuron type with bladder bowel involvement, saddle anesthesia, and loss of erection. But it is a diagnosis of the Corda equina syndrome or the Kunus medullary syndrome. How do you differentiate the Kunus? There is another case, localized backache, sudden paralysis below the knee, vertebral bladder bowel, initially lower motor neuron type, that is spinal shock, followed by the sensory, upper motor neuron, and the weakness. So what is the diagnosis? Initially, sudden paralysis. It's a localized backache, but sudden paralysis. So basically, it is a neoplastic condition. Most commonly, it is an intradural extramedullary. So that is how it is a localized backache. Okay. Similarly, localized backache, girdle type, girdle-like pain, sudden paralysis below the knee. So initially, the same type of shock, spinal shock, followed by the continuation of this lower motor neuron type. This is not at all a orthopedic problem. See, this is localized girdle type of pain. This basically, I've already told, it is a girdle-like of pain. It's coming from the thoracic spinal cord. Thoracic, because the girdle-like pain is the thoracic spinal cord. It is D7 to D10. The D7 to D10, the dermatome is in the abdomen. It is in the abdomen. So there's the girdle of pain, sudden paralysis, and lower motor neuron initially shock. Once the shock recovered, again the lower motor neuron type of paralysis persisted. Symmetrical lower motor neuron paralysis persisted both the limbs. It is a Guillain-Barré syndrome. Or there is maybe transverse myelitis. This is not the orthopedic problem. And there is a diffuse backache. Diffuse backache, maybe at the night. See, this is the at the night. Mechanical backache. See, this is the if it is a disc prolapse, that can lead to mechanical pain. If it is a infective, that can cause severe pain in all throughout the period. If that can increase in the daytime. But if the daytime pain is not very much, but pain occurs mainly at the night, and that leads to sudden paralysis below the knee. Bladder bowel, initially there is a shock-like syndrome, initial spinal shock, followed by the sensory, upper motor neuron, and the weakness. That is the cervical, that means the spinal cord compression. That is the spinal, as it is diffuse funicular backache, especially at the night. It may be intradural, intramedullary, spinal cord compression. There are several causes, of which the most common cause is the neoplasm. So see, this is the way, this is the 5 examples of the basic tips for diagnosis of the spinal problem. Now see, they are not just I'm going to, your life is easier. Some low back pain, there are intermittent pain and the constant pain. If the intermittent pain is a diurnal variation, there's the activity increases, rest relieves, it is the mechanical pain. Similarly, it is opposite. Rest increases the pain, activity relieves, it is the inflammatory pain. Whereas if it is a constant pain, there is a constant pain in day and night throughout the pain, but there is activity increases, but no relieving factor. There is a sinister significance. It may be infective or the neoplastic. Okay, and basically this mechanical pain, the main character, there is another special character of mechanical pain is the claudication pain. Now, sometimes it is asked how to differentiate between the neurogenic and the vascular claudication. There are several differences. I'm not going into detail. Mostly it is theoretical. Most important, distance is variable, whereas distance is constant. Pain is more complaint of neurogenic. It is going on the downhill, whereas in the vascular going on the uphill. Because it is against gravity, vascularity reduces. Whereas going on the downhill, the spine is extended. In extension of the spine, spinal canal reduces. Spinal canal diameter lessens. That causes much more compression. So that is the neurogenic claudication causes pain more on the downhill. And also there's some neurogenic signs will be there. And the relieving factor is the change of the posture, forward bending. Forward bending increases the diameter of the spinal canal. That reduces the spinal compression. And whereas the vascular relieving factor is the rest. Any form of rest that can reduce this. So these are the basic difference between this compression. Now this spinal cord compression. So basically, what is that? How to identify whether there is a compression of the spinal cord? Spinal cord compression initially leads to shock, followed by either upper motor neuron or the lower motor neuron paralysis. I've already shown it. So, this is the most important. It may be extradural or maybe intradural. This is a branch may be coming outside the dural space. That means it may be metastatic tumor, carry spine, this prolapse, vertebralitis, trauma, and osteophytes and degenerated spine. These are the all causes of the extradural compression. Whereas intradural compression may be intramedullary or the extramedullary. Extramedullary, that means outside this cause is outside the spinal cord. Intramedullary cause is inside the spinal cord. Of a most important cause is the neoplasm. Other causes is I already told. There are some vascular problems, arteriovenous malformation, or the hemorrhage. It may be traumatic or maybe hemorrhage and several other causes also. But as extramedullary, that is intradural extramedullary, that may be the most common is the meningioma, that may be MRI. We can see the dural tail or the Schwann or the neurofibroma. In MRI, we'll see the dumbbell-shaped tumor, which is the Bengal type of tumor that can lead to this compression, extradural compression. Other causes, the rare causes, the infection or the sarcoidosis. Now gait. Now another it is a vast subject, and if you so I don't know whether I will get the much more time to discuss all the controversial points. Like gait should be examined or not. Whether it should be examined first or the last of the examination. See, it may be asked to the students also. How the students will answer. Try to understand whether the spine is stable or not from the history and the examination. If you find it is stable, so it may be examined later. It may be at first. Otherwise, it may be unstable. Then you should not examine the gait. Okay. So see this lateral margin of the trunk. See the lateral margin. But if it is abnormal, asymmetrical lateral margin of the trunk or the symmetrical or symmetry of the trunk space, we do the scoliosis. So you have a prominent scapula convex side. You can see here. So these are the three conditions. Where is this? Which one is the scoliosis? So see this is this spine convexity towards the right side. So you can see here convex towards the right side, and then see the scapula is it is higher up and is much more prominent. So this is the scoliosis. Whereas you can see here scapula is almost symmetrical. It is a pure coronal deformity, but the scoliosis is a triplanar deformity. But see on this side, this boy, this has a this is the convexity towards the right, this side, but this scapula is prominent on this side, whereas scapula is not visible at all on that side. On the contrary, there is some typical cafe outlet spot is visible. See, there is almost no neck, and there is a low hairline. This waving of the neck. So this is not a case of scoliosis, or this is yes, that maybe there is a scoliosis, but there is some other problem. This is what is that? This is a Klippel-Feil syndrome. You can see here, it's a Klippel-Feil syndrome. Okay. Now scoliosis. How do you know whether it is uncompensated or compensated? So how to measure the dropping the plumb line. Okay, so we have if it is a see the occiput, whether the occiput is the midline or not. If the occiput is in the midline, it is compensated, not midline, it is not compensated. How to demonstrate? How to demonstrate in the examination? So we have to find out the C7, which is the most prominent spine. You can see here, though it is palpable, it's a T1, So, okay. So the C7, from C7, if you drop the front line, that should cross the natal cleft. If it is a compensated, as you can see here, this is scoliosis, but still it is compensated. Whether this C7, it is not at all is passing to the natal cleft. So this is uncompensated scoliosis. Now, don't forget to check the unusual size. So in front of the chest wall. So suppose it's a pectus carinatum. What is the significance? Children under 10 years of age with thoracic spine tuberculosis for a long time with thoracic kyphosis, that can lead to this. Not only that, there are some other areas to check where there is a cold access is possible, like see this is the superior lumbar triangle or the Petit's triangle. Now the examiner may ask, if there is some suspicion of the psoas abscess, how to demonstrate? It is not visible, but it may be there. So how to demonstrate that there is presence of the psoas abscess? This is the answer. Try to insinuate the fingers towards the iliac fossa. So if there is a psoas abscess, it is severe painful. There is severe tightness. So you cannot insinuate the finger medial to the iliac crest through the abdomen. So this is the way by which you can understand if there is a presence of cold abscess or not. Okay. Now elicit the tenderness. So now this is the catch, because you can see here. See this catch. We have to stand on the side to check the face. Facial expression is most important. So we have to press the base of the spinous process to rotate. Try to rotate the adjacent spinous process in opposite direction. This is the tips for elicitation of the spinal tenderness. Don't try to elicit the angle and also the thumping. Thumping is not required. Thumping is not required. That can cause severe pain. Okay. Now the neurology. So neurology. Now another important is the movements. Just how to check the movements. So for the cervical region, all of you know there is a forward bending, backward bending, side bending, as also the rotation. Now the examiner may ask, is there any way to quantify the movement? Yes. So if you ask the patient to clench the teeth with a spoon and then to examine the movement, then the movement of the spoon through the horizontal or through the vertical, you can easily understand how much forward flexion or backward bending, lateral bending is possible. So this is the way to quantification of the cervical. Now how to check the dorsal movement, movement of the dorsal spine. Always ask the patient to sit down so that the lower limb becomes fixed and there will be no rotation on the pelvis. If the patient sits on a stool or a chair, so after that, ask the patient to keep both the hands on the waist, so that once the patient rotates, so from the vertical or from the sagittal plane, you can easily check the amount of rotation, and you have to see from the above. So the patient will sit, examiner will check the movement of the rotation of the dorsal spine from above the head. Okay, so that you can easily understand how much rotation is on the right side, how much rotation on the left side. Okay. For the lumbar region, you have to check the forward bending as also the backward bending. For forward bending, there is a Schober's test. Schober's test may be the one. There is a simple Schober test. The original Schober test is examined from the C7 vertebra to actually the line joining the dimple of Venus. That is the original Schober test. There is at least 50% of increased rotation. But it's the modified Schober test. That is that we have to join both this dimple of Venus, which cuts the S2 vertebra. Then there's 10 centimeter above, and from that line, that area is examined when the patient bends forward. If there must be 50% increase of that space. But there's a fallacious. Why? Because there is some amount of rotation. There's nutation, counter nutation is also occurring below that line. So the modified Schober test, which is done, that is a 10 centimeter above the line joining this dimple of Venus and 5 centimeter below. So 10 above, 5 below, 15 centimeter. Ask the patient to forward bend and again to check whether there is a 50% increase of that distance or not. This is the modified Schober test. This is for the movement. But if there is any severe painful condition or unstable situation, don't examine the movement of the spine. It's most important. Now come to the neurological. So neurological, so we have to see, you have to check, always you have to tell the higher function is normal, the cranial nerve and normal, and the upper limb, whether the condition of the upper limb is normal or not. First, before jumping to the lower limb, always we have to check this one. Next, we have to follow this sequence: motor, followed by the coordination and the sensory. For the motor, we have to check the bulk, the reflex, followed by the coordination and the sensory. Now, how to check the tone? So first, this is the technique. First, to roll the limbs to check the resistance. Okay. First, you have to check the roll, and next, elevate the limb like this, and suddenly move the limb to check the resistance, because tone spasticity is the velocity dependent. If you take a very slow movement, you cannot check. So you have to make a sudden movement. Okay. Now, so there are find out some highest motor paralysis level for the upper limb. As you can see here, this is a very easy way. I'm not going to detail. This is the theoretical one. C5. So if you check the elbow flexion, it is normal. C5 is normal, like this. If we check the EHL, it is L5. It is a FHL, it is S1, like this. For the thoracic spine, there is no MRC grade. You cannot use the MRC grade. Okay. Another tips of MRC grade is MRC grade should be told grade 3, grade 4, grade 5, only then, only then, if there is some whole range is possible. Like if the whole range is possible against gravity, then only we can tell it is grade 3. If the resistance against resistance, whole against resistance, is whole range is possible, so then we can tell it is a grade 5. So whole range of motion should be there for telling whether it is a MRC grade 3, 4, or 5. For the thoracic spine, we cannot classify according to the MRC grade, but we have to check the intercostal muscles and the Weber sign. Intercostal muscles movement, that's the chest expansion. Chest expansion should be examined at the level of the nipple, that is a fourth intercostal space. There should normally should be more than 5 centimeter. But if it is a 2.5 to 5 centimeter, it is a borderline. If it is less than 2.5, it is diagnostic that there is some less movement of the costochondral, that is the thoracic spine. That may be the possibility of the ankylosing spondylitis, spondylorthopathy. Another important sign is the Weber sign. What is that? I'll tell what is Weber sign. It's extremely important, and then for most of the students, they don't know whether how to elicit the Weber sign. Now the reflexes, I will show the Weber sign later on. Now how do the reflexes? Reflexes, always the deep reflex should be examined first because it is a monosynaptic. Whereas the superficial reflexes should be examined last because it is a polysynaptic. What are the tips? Tips that you have to do the adequate mental relaxation. Sometimes the Janki maneuver can be used. Keep the muscles free. There's the least contact with the body or least contact with the bed. I will show what is the, I will check it. For the just like the knee, for the knee jerk, how is the best way to elicit the knee jerk is dangling the leg from the couch. So nothing to be hold about. So if the patient, the limb is hanging from the couch, so just to tap the ligamentum patella over that, and that can easily elicit the knee jerk. Similarly, the ankle jerk, ask the patient to try to prone or the lateral, so that if the patient is stable, then you have to easily identify by making the patient prone. So, and there is nothing to be hold about. Just to tap on the tendon Achilles, that will be, and gravity will help you the stretching. That is the way to identify this ankle jerk. Now see the patellar clonus. How to discuss the patellar clonus? So you have to first you have to stretch the patella like this, and you have to just insert and pull. So this is the way of description of the patellar clonus. Now the plantar. Now plantar is basically it is a cutaneous nociceptive reflex. So what is the root value? It is a L5S1, but the tips is, you can see here, tips. Check it. Yes. It's just simple touching on the lateral border of the feet by the hand. It is sufficient enough to check whether this is that is great toe is going ups or not. So first use the finger for the light touch, because if we start to give the nociceptive stimulus, that can cause withdrawal syndrome. And withdrawal, that is very difficult to identify, though the withdrawal may be considered as a positive response. So first, just touching again, check it. So it is very easy to diagnose. Just simple with the help of your thumb tip. Just a simple touching that can elicit the upgrowing plantar. But if you give a nociceptive, then see this is a withdrawal. Okay. So initially, if there is no response, then you have to use the nociceptive stimulus. So you have to check, we have to start from this skin, the junction of the skin between the dorsal and the sole that is at least 1 to 1.5 inches above the level of the heel, go along the lateral border up to the head of the metacarpal, then along the transverse metacarpal arch to go up to the base of the great toe. So this is the way. Why it is important? Because the S1, we have to start with the S1 followed by the L5, and once sometimes the area receptive field may be increased. So in that case, they easily it can diagnose. So if the receptive field is increased, there are several other ways. I'm not going to detail: Shadow, Copenhagen, Gordon, Schoffer, and the Ping. But most important is the upper limb. The upper limb is Hoffman just squeezing the terminal phalanx of the middle finger. There is a flexion of the other fingers and the adduction of the thumb. This is the upper motor neuron equivalent of the upper limb. That is the spasticity of the upper limb. Now, this is the beaver sign. How to perform and interpret? You you can see here, as the patient is supine position, ask the patient to make a supine position with the exposure. Now keep the hands across the chest, then attempt to get up forward by forward bending of the neck, and observe the movement of the umbilicus. See the movement of the umbilicus is going up. See, it is going up. That means what is that? There's a paralysis of the lower part. So that is the indication. That is the paralysis of the lower part of the abdomen, which is innervated by the D11, 12 D. So umbilicus is the D10. The lower part is the D11, 12. So there is a paralysis. There is a spinal cord level of paralysis is D11, 12. So spinal level is a D. So if they're moving upwards, is paralysis of lower rectus. So that is the indicates the spinal lesion is the D78, 9, and the cord lesion is D10, D11. It may be D10 or D11, 12. Now, sensory. So how to start? We start from the pain, temperature, tactile, vibration. Now, which type of tuning fork we have to use? Tuning fork is the 120 hertz. You have to use for this vibration sense and the position. What is the importance? Vibration, the position sense that indicates the posterior, the dorsal cord. And the stereognosis. What is the importance? Stereognosis is diagnose the combined pathway or the cortical sense. So now, most important is how to detect the position sense. As you can see here, you have to show first you have to show to the patient that this is the upward position, this is the downward position. Now ask the patient to close the eyes, hold the proximal phalanx like this. Now hold the sides of the distal phalanx and the move. Don't hold the leg, don't hold the rigid anteroposteriorly. Always side to side. Because if you press it, that will cause a pressure sense or the deep touch sense. That is the spinothalamic tract. This is not the dorsal movement. So we have to make a gentle holding side to side and just make it upwards and downwards. As you already shown to the patient, which one is upward direction and downward. So patient will be, if it is a normal, patient will be able to tell whether it is upward or downward. Where if it is abnormal, he will not be able to tell, and that is the dorsal column. So it is most important. So another important question is, now suppose there is anesthesia in both the lower limb, there is anesthesia in the lower limb. So sensation should be checked from above downwards or from down upwards. What is the answer? Both to take. So the answer is we have to check above downwards and also down upwards, both. Why? Because there is some anesthesia. Initially, there is a lower part, there's anesthetic area, then the hyposthetic area, then the normal area. So if we do either above down or the down upwards, you can miss the area of the hyposthesia, which is also the area of abnormality. So always have to check both the ways. So that is most important answer. Now, how to assign the involvement? So see, is the upper motor neuron type? It may be due to cervical and thoracic myelopathy. If it is a lower motor neuron type, it may be root involvement or the cauda equina. When root involvement, there's the most common is the PIVD. There's prolapse intervertebral disc. But the cauda equina, most common is again it's a prolapse intervertebral disc. But then the other causes are the trauma, tumor, tuberculosis. Always the TTT. It can easily identify, easily remember. Trauma, tumor, tuberculosis. And this is the most important cause of extradural compression also. And epidural hematoma abscess is also another cause. Now, mixed lesion. It is very rare. Sometimes it is a mixed lesion, upper motor neuron lesion and the lower motor neuron. Mixed lesion may be as what is the cause? It is very rare because most of the cases is non-orthopedic condition like the motor neuron disease, syringomyelia. This is really seen. But very rarely in orthopedic case, there is isolated conus medullary syndrome. Then you can see there is a mixed upper motor and the lower motor. So pattern of involvement, detect the extradural and intradural. I've already, I think it is, I'm explained it. Why it is extradural and intradural. Extradural, it is coming from the front. So tuberculosis, it involves the motor tract first, followed by the sensory, then the bladder bubble. Whereas the intradural, as it comes from the back or from the lateral side, it involves the bladder bubble and the motor sensory in the very early day. No, not the spinal signs. Character of the pain, detect the intra and extramedullary relation. So if the character of the pain is that it is a radicular pain, it is extramedullary. So because intramedullary relation, there is a diffuse pain. Patient cannot identify the exact site of the pain. Now, how to differentiate between the conus medullaris and the chorda equina? What is the importance? Because these are both are very, very medical legally, they are most important, because if you miss it, you can become liable to give a heavy price, because there is both are orthopedic emergencies. Once it develops, that may not recover. So conus medullaris, what is that? Conus medullaris basically is the lower part of the spinal cord, which carries the D12, T, L1 and L2. Whereas the chorda equina, it is a bunch of the roots, bunch of the peripheral nerves below the level of the L1, basically L1 vertebra. So it contains basically the nerves of L1 to L5 spinal nerves. Most important, the L3, L4, L5. Common features of both are orthopedic emergencies. There is loss of the motor and sensory to the leg, below knee hypostasia, hypotonia, and hyporeflexia. Bladder involvement, that is a painless retention of the incontinence. There's an anus involvement, there is a loss of the fecal incontinence, and also there is some loss of perineal problem, there is an erection problem. I already told, if there is erection problem, it is a very sinister significance, that may be conus medullaris or chorda equina. And there is a saddle anesthesia. That means if the what is the saddle area? Saddle area, if the patient rides on a horse. So the area which is contact with the horse, that is known as the saddle. So that means the inner aspect of the thigh, inner aspect of the buttock, and also at the around the anus and the genitalia. This is the area, the saddle area. Then this area becomes anesthetized. And also there is some backache and the side. These are the common problems. So how to differentiate between the conus medullaris and the chorda equina? See, the chorda equina, that may show the asymmetrical, that may cause asymmetrical problem or unilateral distribution. Whereas the conus, as it is in the central part of the spinal cord, there is always bilateral symmetrical distribution. So isolated conus medullaris may show the UMN signs like spasticity or the hyperreflexia. So how did the bladder involvement? Bladder may be the upper motor neuron type when there's a lesion above the T12 L1. So basically the bladder, the sensory is coming from the L1, L2, whereas this motor, this detrusor is supplied by the nervy regions, that is S2, S3, S4. So if the lesion is above the T12 L1, this is upper motor neuron type. This may be either automatic bladder, cord bladder, the thimble bladder. So there's a detrusor sphincter dyssynergia. That means that detrusor is filled up, but it cannot open up because this external sphincter is closed. So that is a back pressure to the kidneys. That is a significant important that because that can lead to the renal damage. So you have to identify. Whether you can feel the fullness of the bladder, no, because the sensory level is already involved. But whether the lower motor neuron type of bladder, patient can feel. The L1, L2 is not involved. So the sensory, you can feel the feeling of the bladder. And another is the weight. Yes, weighting is yes.
Yes, sir. Sir, it's 9:40. May we take few questions? Sir?
Yes. Okay. I'm just making a simple summary. Just how to make a summary. This is a 34-year-old man presented with limping for last 22 years, following severe pain in the back, treated conservatively for a long 1 year with some daily medicine, with initial relief in the sense of relief of pain, but limping persisted without occurrence of any complaints like bladder bile complaints, loss of the body weight. On examination, patient has a bipedal unassisted but cautious short step gait with components of the circumduction. There is a dorsal gibbous deformity involving the D7-D8 with compensatory lumbar hyperlordosis, no local spine tenderness, spine motions are terminally restricted. Neurologically, patient is conscious cooperative, normal cranial nerves, upper limbs with symmetrical wasting of the both lower limbs, spasticity involved the muscles around the hip, knee, and ankle without sensory bladder involvement. So what is the diagnosis? See, there's a spasticity. That means the cord is involved. Initially 22 years back, the severe pain in the back, conservative for 1 year treatment. So there is a possibility of Kelly spine. After that, it is persistent. That means what is that? What is the complication of the Kelly spine that leads to persistence of the spasticity for a long time? That is the internal kippers. So basically, it is a persistent compression, extradural compression of the spinal cord. It may be due to the dorsal region, or this is at the D78 level. So it is a persistent compressive myelopathy of the dorsal spine with thoracic cervical thoracic myelopathy with persistent spasticity in a 34-year-old man. So this is the diagnosis. So in this way you can diagnose. So I am stopped here. I will love to discuss what is the other dilemmas.
Great. Thank you very much, Professor Pal. I think we can open this session for questions. And I'm sure there should be some from the students and the...
So while we are waiting for the questions, sir, one thing which you have explained about the extradural, intradural, extramedullary and intramedullary. So is it that intramedullary is always upper motor neuron lesions, or it may be lower motor neuron lesion also? Symptoms of lower motor.
See, it is the intramedullary. Intramedullary means inside the
So
spinal
where
cord.
is the medulla in the spinal cord?
Yes,
Yes, sir.
intramedullary means the spinal.
So once you come
Spinal
down to the
rotation.
lumbar level, you don't have a medulla, huh?
Intramedullary means it is inside the spinal cord. So what is the cause? I already told most common cause is the neoplasm. Next common cause is the vascular problem. It is the hemorrhage, or rarely there is some infection. So if it is involves the spinal cord, suppose it is a dorsal spinal cord is involved. So the area below the dorsal area, so the dorsal spinal cord, that is the lumbar area, must be some upper motor neuron lesion. You understand? So if it is a spasticity, spasticity is there. So you always consider there must be some spinal cord involved. Okay, is it clear?
Yes, sir.
So anything that is intramedullary is also intradural. Okay, but everything that is extramedullary does not need to be extradural. But the cord only comes down to the conus medullaris area.
Yes,
So
sir.
anything involving the cord will have features of upper motor neuron. Plus they won't have very pointed root sort of levels, okay, because it will be a more diffuse kind of area of involvement as opposed to the extramedullary.
Yes.
I'm telling you, the lesion may be inside the spinal cord, lesion may be inside the root. Okay, so or it may be lesion in both the spinal cord and the root. Okay, so if it is in the spinal cord, so suppose spinal cord, suppose it ends up to the level of the lower part of the L1. So suppose the dorsal spinal cord is involved. So the area below it, that means that it is the upper motor. Okay, suppose the D7 spinal cord is involved. So it is a D for the D8, D9, D10. It is in the upper motor neuron lesion. Okay. So in the lower the area below the D7, there must be upper motor neuron lesion. Okay. So there is spasticity, everything. Spasticity,
yeah. So I think if you have both intramedullary and extramedullary features, then it becomes a more mixed picture. So I think trying to distinguish that becomes more difficult, but basic differences between intramedullary and extramedullary should be clear to people. Okay.
Yes, I'm telling you. So if it is an extradural,
I think it should be clear to people. I don't think we need to say it again so many times.
With the extradural, then it is always that means the root may be involved. Okay. Suppose it is coming from the vertebral body. Suppose the Kelly spine, the abscess is coming, or abscess sequestrate is coming from the vertebral body to press the spinal cord. So that is outside the dura. This coming from the branch is coming from the outside. That is extradural. So extradural, first it involves the root. Then it's the spinal cord, because root is outside that dura, isn't it? So the roots is involved. So that the local part, that means the roots, that is lower motor involvement, and then this spinal cord is involved. Then there is upper motor involvement. So if it is coming from the outside, that may lead to both. Okay. So that the area of the involved, suppose in the D7 area, and the D7 area there is a D7 is a lower motor, and the below the D7 it is upper motor neuron. Okay.
Yes, sir.
But
So,
but if it is a pure root involvement, and suppose it is a disc only, the lateral disc that compresses only the root. So the no spinal cord is involved. So it is purely it is a lower motor neuron type of tissue. Okay.
yes. So there is one question in the chat box by Arindu Pandit. You want to know what is the right way to find out the affected spine and nerve involvement level?
Nerve involvement level. Okay. So I've already told Shyam how to identify the location. So I told the maximum upper motor of the upper level of the motor paralysis and the sensory paralysis. So you have to suppose it is I've already said the Weaver sign is positive. If the Weaver sign, that is umbilicus, is going up, that means lower part of the lower muscles of the below the umbilicus is paralyzed. So what is the root value? At the umbilicus is D10, below the umbilicus is D11, 12. So it's a spinal cord level is the D11, 12 is involved. Okay, this is a maximum upper motor level. Okay, so if it is a D11, 12 spinal cord is involved, so what is the spine? Spine means we have to minus. So what is the method? That means if the cervical region, add 1. Okay, for cervical region, for D1 to D6, we have to add 2. Okay, D7, 8, 9, we have to add 3. Okay, so if it is a D9 spine is involved, the spinal cord is involved, 9 plus 3, that means 12. Okay, so if it is 11, 12 spinal cord is involved, spine should be involved minus 3. Okay, that means it is D8, D9. So in this way we can identify if the D8, D9 spine is involved, D8 plus 3, 11, 9 plus 3, 12. So it is 11, 12 spinal cord is involved. Okay, so in this manner you have to calculate.
So there is another question, sir, by Dr. Subhanshu. How do we rotate the adjacent spinous process? Well, for the tenderness when we.
That is simple. First we have to identify the spinous process. How to identify the spinous process? So either from above or from below. So above, that is a vertebral prominence. In spine cases, the some area must be marked out. That is the spinous process. So from above down, all the spinous process you have to mark it. So examiner will see whether you have marked or not. Okay, you have to mark it from C7 downwards. From the below upwards, the highest point of the iliac crest, that will corresponds to the L4 spine. Okay, the other points are not very sure about it, because there are some intra-observer variation. That is the lower part, the inferior angle of the scapula, that corresponds to D7, and the lateral angle or spine, that should correspond to D3. But these are not significant. Only most important constant is the C7 and the L4. So from above downward, we have first to add. Now once it is identified, first check in which area there is a maximum deformity. That is which area there is a kyphosis. There is a gibbous deformity. Okay. Suppose 3 vertebrae is involved in the gibbous deformity, D7, D8, D9. Okay. Then we have to check the base. We have to hold both the vertebra like this and to rotate in this opposite direction. Like this. To hold both the vertebra. Okay. Both this, that is spine of the vertebra, and we have to rotate in this manner in opposite direction. So that is the way to check that is tenderness or not. Otherwise, you can check individually. Just to press the base of the spinous process and to check the face whether there is a abnormal facial expression, painful facial expression or not.
So I think we have covered question. Just one confusion during the lectures about the gait. You have told when to say the gait in hip and spine case. Both, sorry.
The simple answer is we have to examine better. Don't examine the gait first. Okay, because you have to try to understand whether the spine is stable or unstable. If there is a carry spine, patient is a non-ambulatory, never examine again. Okay. But suppose it is a prolapsed intervertebral disc. In that case, the limb spine is stable. But the patient is complaining of pain. There is some weakness, but that is a neurogenic claudication like that. So try to understand whether the spine is stable or not. If the spine is stable, then you have to examine the gait. There is no problem at all. Suppose it is ankylosing spondylitis, there is Simeon's gait. That is, patient will walk like this. That is both the limbs in front. There is a forward bending, and the looking gaze towards the ground. So this is the way that gait must be examined, because that is a the spine is stable. So try to understand whether the spine is stable or unstable. If it is unstable, never examine the gait. Okay, even during the change of the position, you have to ask some persons to come follow out the exam, tell the examiner, sir, I can change the position of the patient with the help of at least 3%. So for the log rolling technique, at least 3 or 4% is required for log rolling. So please provide me, sir, 2 to 3% for changing the position. So if you consider that the spine is unstable, don't examine the gait. If it is stable, then you can have to examine.
So, one last question by Anandu Pandit, that in case of tubercular paraplegia, whether we should comment about paraplegia in flexion or extension.
Definitely. In spine, you have to tell whether it is a spinal cord compression, whether it is a extradural compression, extradural intermediary or extradural compression. Okay. Next, next you have to tell whether it is recovering or not, whether the patient is it is in which stage, whether it is in stage 3, that means that is paraplegia inflection or paraplegia extension, because that indicates the prognosis. If the paraplegia inflection, that is a bad prognosis. Definitely, you have to tell. You can, if you are able to do that, you have to tell the stage of that. This is a paraplegia. There is spine. It is a extradural extremely compression of the spinal cord following tubercular spondylitis with stage 3 paraplegia inflection, paraplegia extension. Okay, with suffering from carry spine of 6 months duration, not recovering with antitubercular drug in a 42 years old male like that. They have to tell like that. Okay.
Okay, great. Thank you very much, everybody. And thank you, Professor Pal, for an excellent talk. I think we should close the day now. So until next week, hopefully we'll see you again. Okay.
Thank you very much, sir. Thank you, sir.
So we now leave the meeting and then we have another meeting. Yeah.
Yes, sir. Thank you, sir.
Will you stay or will you stay or log out?